All right, so let's go over the extubation procedure. Typically, you should be able to do this by yourself. Most individuals, they're getting extubated, they're going to be attached to a mechanical ventilator. And that's not necessarily in all cases, but for the most part, that'll be the case. I'm going to have to silence this alarm over here. Our oxygen cell is bad on this particular ventilator, so we need to replace that. But nonetheless, let's talk about the extubation procedure. You really should, if you're going to extubate, one, check your chart, make sure you got an order to extubate, make sure that you've got the right patient, verify the correct patient, that is the individual that you want to extubate. And then you go through your assessment. So chances are, if you're at the point of having an order for extubation, you probably passed your SBT, your wean screening, things along those signs, and hopefully your patient's cooperative and able to do, like for instance, I may come in to further assess their readiness, what have you. I'm going to ask them if they can pick their head up off of the pillow, because that'll kind of give an indication of whether or not that they can protect their airway, make sure that they can follow commands. I might ask them to squeeze my hand or wiggle their toes. And if they're looking at me and tracking me, I may ask them to a couple of questions, to nod yes or no. Most of the time when I ask if they're ready to have the breathing tube out, they're quick to nod yes. So as far as the actual procedure of itself is concerned, you got a couple of things that you've got to get ready. You know that you want to pre and post hyperoxygenate your patient. So to help with the pre-oxygenation phase, what I would do is on your ventilator, this is the servo eye, so you've got an O2 breaths button here. You can hit that, and once you hit that, it's going to give 100% oxygen for the duration of about 2 minutes. That particular button should be available on most ventilators, but it may be called something different depending upon, like for instance on the VIA, you usually have a suction button. You have a suction button. There's also an increase O2 button. By hitting the suction button, that silences your alarm on the VIA, but also provides you 2 minutes of 100% oxygenation to your patient. I'm going to reset this. So while I'm getting everything set up, I'm going to go ahead and hyperoxygenate my patient. So I'm going to hit the O2 breaths button. That'll activate my O2 breaths. My cannula, I've already got my nasal cannula set up over here. Turn it up to 2 liters because that's what I'm going to extubate to. Now you may decide to extubate to a face shield to provide a cool blend aerosol or anything to that effect. But a part of the rest of the assessment piece is making sure that you've got suction set up. So you've got suction here because this is going to be your last access for a little bit, direct access to their lungs. So I always like to suction before pulling in the tracheal tube out. Have a yonker ready to roll because I'm going to clean their oral secretions, but I'm also going to clean the secretions off the top of their cuff. So now I'm just going to do it, and I'll try to talk about it and teach it as I do it. I also utilize a blue chuck because I'm going to pull everything out and discard it. So what I'll do is I'll let the patient know that I'm going to lie this across your chest, lay this across your chest, go ahead and get it up under the ventilator circuit and everything. And again, I've come in, done my assessment, squeeze my hands, can you pick your head up off the pillow for me? And you could ask them to cough, but you're going to find out if they can cough here in a minute when you suction their airway. So I'm going to, assess their breath sounds, make sure that they're doing okay there. I'm going to come in and I'm going to suction in the tracheal tube. They're already being hyperoxygenated. My alarms are silenced, so I can tell them, all right, you're going to cough here momentarily. So I'm going to take and run this catheter down. Big cough, and once you hit the carotid, remember, back up just a little bit, then apply your suction. They're going to cough if their cough reflex is intact. Cough, you can clean them out, suction them. If you get a fair amount, you may decide to make a second pass. If you didn't get much, you may just stick with your first pass. But because at this point they will have coughed, and let me silence this alarm again. Because they've coughed, they've generated pressure. They may have blown some secretions up around their cuff, or from lying in the kind of the semi-Fowler position that they're in, we know that fluid's going to follow gravity, so that those secretions may pool on the back of their throat. So now I'm going to disconnect from here and let them know that I'm going to suction the inside of your mouth. This may cause you to gag a bit, but we want to get the spit that's in there. So I'm going to take the yonker, your tonsil tip suction device, and go down the base of the tongue to the top of that cuff and suction any secretions that may be on the top of that cuff. Notice that I'm doing this before I assess for a cuff leak. because if I assess for a cuff leak first and haven't suctioned the secretions off the top of the cuff, once I drop that cuff, any secretions that were there are going to drop down into their lungs. So I've already suctioned the endotracheal tube. Now I've suctioned the secretions off the top of the cuff. I'll leave this suction ready to go because that's what we're going to have. So now I'm going to assess for a cuff leak. So with my stethoscope, I'm going to place the stethoscope in my ears and place the diaphragm over the throat here, and I'll take a syringe and I will drop the cuff slightly. Now, one thing I want to mention, you should hear when you drop the cuff with your stethoscope there, you should hear a gurgle. You should be able to hear air escaping around that cuff with your stethoscope over the neck. You'll also, if it's a significant enough leak or good enough leak, you'll hear gurgling coming out of the mouth. You may also notice a drop in pressure or a drop in volume on your mechanical ventilator. So once I've verified that I do indeed have a cuff leak, while I'm getting everything else ready, I'm just going to put the air back in the cuff so I no longer have a cuff leak, but I've verified that I have a cuff leak. Reason you want to verify your cuff leak, let me silence that again. Reason you want to verify your cuff leak is because that endotracheal tube is sitting through the vocal cords. Typically an endotracheal tube is not supposed to be through those vocal cords. So it sits there, it could irritate the airway. Maybe they've got some kind of other inflammatory process going on. So if I drop the cuff and I don't hear any air, then that means that the larynx, the vocal cords, what have you, may be swollen. And if they're swollen significantly enough, if I pull that tube out, it's possible that they may finish closing off, and then you got to try to get the endotracheal tube back through there. And if you're unable to do that, then assuming they fail extubation, then you may have to, not you, but someone would have to do an emergency cricothyrotomy or something to that effect, emergency tracheotomy at the bedside and insert a tracheostomy tube. So we want to try to avoid that if we can. So make sure that you're assessing for a cuff leak. Now there may be some scenarios in which you don't hear a cuff leak and the doctor wants to go ahead and move forward with extubation anyway. So at that point, you got your cool bland air, you get a cool bland aerosol set up, have your racemic epinephrine pulled and ready to be nebulized immediately afterward. And they may actually do a series of systemic steroids before, so that those steroids can kind of counter the inflammatory process. But with this patient, we're not going to have that because hopefully this is going to be a smooth extubation. So I've hyperoxygenate. I'm going to hit the O2 breath button because I've been talking for a little bit, so I'm going to let him hyperoxygenate. I've assessed for my cuff leak. I've got suction ready to go. I've got my supplemental oxygen that's ready also afterward. So now what I'm going to do is I'm going to explain to the patient, all right, I'm going to be pulling that breathing tube out. There is a balloon on the tip of that endotracheal tube. I'm going to pull that out. And when I pull that out, I'm going to pull the entire tube out. You're going to cough, but I don't want you to cough until I get the tube all the way out. There's probably going to be some spit and stuff that comes up with this tube, but that's okay because I've got this blue straw here that I'm going to utilize to suction that out of your mouth with, okay? So after I've explained that to you, I'm going to let them know. You're going to feel me kind of pulling and working some of this adhesive loose. So I'm going to go ahead and undo this. We can pull this through to the other side. And with bed sheets and not just a rubber mattress, it'll slide a little bit better. I can go ahead and work these adhesive pads loose. I'm going to work if they are stuck to the face, get a wet rag or a wet gauze bandage and help kind of work those loose. And now the tube is out, or the tube's not out, but the tube is loose and secure once you've done both of those adhesive bandages. So now what I'm going to do, I've got my suction again ready to go. I'm going to tell the patient here momentarily, I'm going to pull the tube out. The tube's going to come with me. I'm going to need you to cough after I get the tube out so that I can suction those secretions out. And then I'll have a little bit of nose. It'll probably tickle a little bit in your nose, but we'll put this nasal cannula on afterward. So if you're ready, I'm ready. So now what I'm going to do, I'm going to place my ventilator in standby. I'm going to let it give a breath. It's giving a breath. I'm in standby. We're going to go ahead and come on out with the tube after. Make sure you deflate the cuff first. And you can leave that attached. That was botched.